we did want to do something a little bit different and just have a bit of an open discussion of an installation of AquaTYPHOON at one of our sites in Bath. So rather than do a bit of a death by PowerPoint, we thought, yeah, we would open up for today. So my name's Charlotte. I'm the regional decontamination manager for the South, for Therapeutics as well. And last year we did a talk on plasma typhoon, so you might recognise similar aspects. But we thought today that we are going to cover AquaTYPHOON. So this sits on the dirty side of decontamination, and the device cleans the endoscopes with turbulent water and air. So there's no detergents, there's no particles, there's no brushes, it's just water and air. So I'm just going to introduce Beverley and Soby. So welcome. If you could just tell us a bit about yourself, your department, how long you've been in the industry, and then, yeah, we can get into it.
Yeah. Hi, everyone. I'm Beverley. I'm the quality manager at the RUH Bath. I joined just over 10 years ago in the department as a technician, then became training manager a few years later, then acting quality manager, and then finally took over quality and resourcing. So the same department, been through a few different changes, quite a lot of change in the past 10 years. I'm working with Soby.
Hello, everyone. My name is Soby Joseph, working in a decontamination field for last 21 years. I work almost every job role in decontamination, starting as a technician, then a team leader, supervisor, then training manager, later deputy manager, now head of service. So we have gone to various changes. I mean, now we are talking about the AquaTYPHOON. 2019, we have done a refurbishment. Before we got 2 satellite endoscopy unit. So 2019, we refurbished and centralized all the decontamination in one area as part of our SSD unit. Annually, we process around 20,000 flexible endoscope and still managing to various locations, theaters, endoscopy, urology. So we're managing that. Over to you, Charlotte.
Yeah, no problem. So you mentioned about how much you're doing with flexible endoscopy. What other departments are you're currently reprocessing for?
So mainly endoscopy department, we're processing around 70 to 78 flexible endoscope per day. Again, theaters, we're looking after theaters and a few scopes like choledoscope. Some of them need sterilization, cystoscope. And urology is the main part as well. We process a lot of cystoscope, and again, we look after ENT as well. So ENT, urology, OPD, and endoscopy. That is our main production areas.
Perfect. And what scope manufacturers do you currently use?
Last year, we did a massive project. We invested around £4 million in our flexible endoscope portfolio. Around 90% from Olympus flexible endoscope. We got a few PENTAX. We got PENTAX, cystoscope, and Storts. We trialed various other manufacturers last year, but we end up with Olympus. And
with regards to the manual reprocessing, what were you doing before AquaTYPHOON?
So before the AquaTYPHOON, we were doing kind of what most people are doing, the endoscope brushes of various different companies and the Scope Valet system.
Okay, and did you have any challenges working with multiple suppliers of scopes and the different IFUs for that as well?
Yeah, we had a lot of challenges with the brushes. We had, originally we'd be with the manufacturer-led brushes. However, often the manufacturer of the scopes are not particularly great manufacturers of the brush. They don't consider things from an operational point of view. So there's one manufacturer where the different brush sizes are all the same color, which is just a disaster waiting to happen. So we had a few instances with inappropriate brush selection by accident, and it would get left inside a scope. I think our Scope Valet system was not necessarily always the most reliable bit of kit, so we were often having to go back to complete manual clean with a syringe, which our technicians hate.
Absolutely, yeah.
Initially, we used the profile brush and later moved to the candle one. You remember the problem with that, some of the brush got 2 different end. One is thicker and one is, I mean, when you train the staff, there is 2 type of method, like a pull through and a pull back. each manufacturer trains staff in a different way. We got 2 incidents. Staff put through the small end first, then push back. The end bit, the camera bit is coming off from the scope. So you know the cost of some of the scopes starting from 9,000, it can go up to 100,000 pounds for some of the E-bus scope. So it's very expensive scope. And again, the various diameter. If you look your inventory or portfolio, you can see diameter for each channel is different. That means the technician need to know the correct type of the brush all the time. And chances are they will make mistakes. And again, then we move to the diagram. You remember this disc brush? And even then, it's a bit easier, but still, if you take, like most of the GI scope is 2.8 is the diameter for the biopsy channel. If you take the small brush, it will go through it, but it won't clean properly. So we got so many issues with the different type of brush, and the staff training, staff is confused. You know that one of the main challenge with the SST, the staff turnaround is always high. We need to train the staff all the time. So that's why we're looking for any innovation coming to the market. We would always want to trial that one. So,
And is that what made your decision to change over and look at something that was automated?
yes.
Yeah.
We've been considering it for quite a while, that kind of investigating the possibility. And then when we had last-minute funding for a complete refreshen of all of the scopes, there was a lot of decisions made very, very late in the financial year, even to manufacture a scope, to model. And so there was really kind of no time to do a proper brush review, get them set up on the procurement system to enable a continuous supply. That's always kind of a challenge. I think procurement in hospitals is increasingly busy, and it's harder to get sustained attention.
Yeah, and how did you go about the change and getting the device in?
So at that time, there is 2 technology in the market. We visited the other hospitals, already installed this technology. Then we end up with the PENTAX AquaTYPHOON.
And did you have to check or align with any other scope manufacturers?
So, I mean, we'd always check, but we are mostly with Olympus. Olympus will only endorse their validated technique, quite rightly. I don't think they really do partnerships with other devices. It would be more of a competitive action for them. They do sell their own brushes. They do sell their own kind of suction pumps as well. So we checked to make sure there was no objections, but we weren't ever hopeful for an endorsement.
Okay.
And again, when we evaluating various technology, the one thing we evaluate the available scientific document. So we review all the scientific document available, and you know, the PENTAX, they did a lot of type testing with the various type of scope. We haven't seen any other product manufacturers actually type test various type of scope, and it's passing. So it's done in France.
Yes, yeah.
So that is quite comprehensive test studies. That's the one of the reason we choose this one.
And I'm not going to sit here and say, with regards to the new equipment and the installation was a little bit, it wasn't as rosy as we hoped. So we did have a few challenges sort of installing the AquaTYPHOON, mainly to do with water pressure concerns, where we've had to have a pump installed and some planning of the installation. Did you come across any other challenges when we did the installation or regarding getting the device into the hospital?
I think because it was new and because it's last-minute funding, it's always at the end of the financial year, there's kind of challenges that you don't really anticipate. We weren't able to plan the actual site infrastructure as well as we would have liked to if we'd planned it 6 months in advance. So we kind of investigated the technology, the validation, but not how it looked on our site. So you mentioned the water pressure. I think that was a failure of imagination. We didn't realize properly just how kind of weak our water pressure was. So it was very last minute that we were testing our mains water, and we had to get a solution in place, which our estates were very supportive of. But then, of course, that pushed back and it delayed the actual commissioning.
Yeah.
And again, I don't know, you don't like it, I said this one, but I need to say, because I'm from NHS, we're using the taxpayers' money. So at the end of the day, every penny we're spending, we need to be careful. So one of the things I noticed, or we noticed, that PENTAX and Wassenberg is sort of sister concern. You may know all these things. PENTAX not in the framework, only Wassenberg in the framework. So we need to buy this equipment from Wassenberg, but all the validation and the service through the PENTAX. So there is a little bit confusion on that element, but it's always like that. So.
And you mentioned about, well, going back to the financial aspects of it, have you seen any financial gains now you've had the AquaTYPHOON for nearly a year?
You know, most of them working for NHS, we need to a contract recommendation report. That's a big document we need to write before purchasing everything. So we identify 15K savings minimum because we're spending around 20K per year for all the brushes. So all the various type of brush forces, Karl Storz need a special brush, PENTAX need a special brush, Olympus. So we can remove all of that different brush. We definitely gain 15K savings from that, and this is a brushless technology, so, and no chemical as well.
What sort of soft gains have you seen? Anything to do with stock management or reduced ordering?
Yeah, I mean, stock management was getting quite tricky because we were primarily getting our brushes through the supply chain, and we were finding we'd find a brush that we'd like, a code that we like, we'd get set up on our procurement system, we'd order it, and then suddenly that would no longer be in stock, or they've done a code change. So it was this constant trying to monitor our brush levels really closely and get ahead of the curve. So that was it's been much less hassle now on that side. And then from the technician point of view as well, the process probably does take a little bit longer, but it's so much less manual and labor intensive as well. There's a lot more flexibility. So because it's a largely automated process, you have a few minutes to go and get kind of prepped for your next task. So it's less walking around, less inefficiency. We've not reduced staffing by any means, but it's better for them. They're less running around like a mad hatter.
Yeah. Has it changed much of the workflow for the staff?
I mean, just at the Beverley's point, you know, the human error element is everywhere because of we using decontamination is a labor-intensive process. So if you can automate, the one advantage is that you will get a validated result all the time. So now, when we wash each scope, you will get a printout, the pressure and everything. So we can complete 100% assurance that every scope is going through the same process, and we will get a validated result all the time. But if the technician is doing, it depends on the person. I have seen some of the staff finish the flexible endosk cleaning within 5 minutes. Some took 20 minutes. So the quality is always different, and it depends on the technician. But now we can assure that we'll get a validated result all the time. That is one aspect. Second element is that you know that flexible endoscope cleaning, like Beverley said, the repetitive, the main process is that brushing. You need to brush. I mean, I don't know, any technicians here, you can see that, you know, if you stand all day washing around 50, 60 scope brushing, is one of the difficult tasks. Now it's automated, so they can connect everything. They can see the machine running. They use the gun. I don't know, you see the AquaTYPHOON. So they use the gun for first phase. Then close the lid. They can. The machine will do the rest of them. So they got a lot of freedom now all the time. If you set up a new service or something, you can save the staffing as well. So usually we allow 3 staff in the wash area. Now we know only 2 because we got 2 aqua in 2 sink. So 1 staff enough for one side and another staff in another side. So technically, if you're planning a new service, there's definitely a staffing saving as well.
And with regards to the validation, how did you change that validation process within your hospital to suit your AD and everyone else within that department?
So we were largely kind of led by you guys as the manufacturer for the validation process. I mean, that I think is something that we're probably working towards. We've discussed, I mean, what we like about PENTAX is that they're willing to have that kind of ongoing relationship. So we've identified things that would give greater assurance. But it's difficult because the validation isn't really something mandated. I mean, who amongst us has kind of validated any different brush solution as well. I mean, often the instructions from the manufacturers for scopes, depending on what you're buying, some of these instructions for use still mandate using alcohol to dry lumens. The Olympus one in particular will mandate using a suction pump. None of, I hope Olympus will forgive me, nobody is selling these suction pumps into hospitals for the decontamination. I've not really seen a decontamination facility using it in endoscope cleaning. So we're always never quite doing the validated method from the manufacturer, but it's kind of industry-led. We're looking for minimization of risk, and then the final output is we are validating all of this through the EWD afterwards. So it was kind of a difficult one. That's why I said we went by what PENTAX have said, and then we've suggested a few things I think you guys are now working on as well.
Yeah.
Our AED is a bit strict on these things. So we are going to do working with IDSC, and we are going to type test all our various model of scope through the new technology. So we getting some quotation from various labs. So we working with one of the main lab in the UK to validate our process is actually. At this time, we rely on the PENTAX validations and things like that. There is a quarterly and yearly revalidation. So we getting, I mean, they're using surrogate scope. But we are going to test with a live scope soon. So happy to share that result if anybody interested.
Perfect. And was there any other sort of soft gains that you guys had in the department, or anything that you would like to highlight?
I mean, Soby's talked a bit more about moving to an automated process. I think the timing has been really helpful as well. So before, you'll see if you're working in the department, you have peaks and troughs of activity. So our decontamination is sat a little bit aside from the procedure rooms. So we go up and we do collections at least hourly, but during the day, kind of more than hourly as well. And you'll go from having no scopes to suddenly you have 10, because we're a site we do a lot of transnasal gastroscopy as well, and those are quick. So we have a lot of kind of towers previously, and it would be kind of technician taking what they think is the most recently used one or the older and go from there. But now that we've got the ticket, we can see when things come in on our scope resection, our traceability, and then there's more of this visual indicator of what needs to go into an EWD first. So that I think is a big benefit when it comes to efficiency. Looking through kind of the data, audit data, we are definitely getting a more timely full processing of the endoscope.
Perfect.
And again, one of the advantages, if you visit when we visit various other departments, you can see a lot of barcode. I mean, if you got 100 scope, you need 100 barcode all over the place. So it's like a barcode warehouse in some of the decontamination area. But we moved to completely RFID. So this AquaTYPHOON also, we can scan staff ID and scope ID through RFID reader. So that is another advantage. Yeah. So you don't need to print anything.
I think that is currently one of the slight weaknesses. So the AquaTYPHOON does come with an RFID scanner, but it doesn't work with any of the commonly used RFID tags in the UK market. I think it works with a lot in the French market. So it was pretty much useless to us, but then we realized that we could just plug in our standard RFID reader into the port, and we're using that. So we haven't had to put an additional traceability at all. We use the existing infrastructure.
Great. Yeah, I was going to say, I think I just want to say thank you for giving a bit of a real life insight